clinical management of non-COVID-19 patients, obviously, that are emergent. You know, it is a hospital. There are other patients who may be unfortunately experiencing a stroke or a heart attack. So Dr. Luca Assaloni, as one of the surgeons, who will be sharing his experience with this.
Okay. Did you hear me? It's fine?
Yes.
Yes, thank you. So I have not prepared slides, but I have sent to Bassam a couple of drafts of 2 articles, 2 editorials that they will be very soon published on World Journal of Emergency Surgery regarding 2 topics. One topic is how to manage an epidemic like this by the system, by the hospital system, the health system. And the second one is which advices we can have in order to treat patients when they go to theater for different situation that is not COVID-19. So according to the first idea, the first topic is the main, and Bassam can share those drafts already to everybody that won't know that, won't read that, is that what we are facing actually is like a mass casualty that every day is a medium mass casualty that brings some patient to our hospital. So it's not like the usual mass casualty where you have just one hit, but every day you have an hit, and you increase the number of patients that are coming to the hospital. What you are looking in your ICU is just the top of the iceberg, and a huge part of the effort of the health system is to manage the patient before reaching there, because they entering in the casualty. You have to make the diagnosis, trying to divide patients that are dirty with COVID-1 and those that are not. And actually, you need some wards where you have to put patient waiting for the test or waiting to be placed in the COVID-1 area, ICU, or less complicated patient with the COVID, if they are COVID-19 positive. So actually, you are facing really, and everybody that will be involved in a mass casualty like this, he has to plan for an everyday mass casualty that will last for at least, regarding to what we know, a couple of months, with the peak that it will be in the middle of that. So for sure, you will have a lot of effort to be put on the entrance of the patient and of the exit of the patient. Actually, our main, the vast majority of our hospital in Italy, they don't have a mass casualty plan. So what the hospital, the only advice that I can give to somebody else is to review the mass casualty plan of every hospital in order to afford a medium mass casualty that they will last for at least 2 months. Second thing is regarding what we do for the other surgical procedure that they have to go to theater. The good news is that we are seeing that all the other emergency, they are reducing. For example, in Italy, we have stopped the people inside in the house, so we are not seeing any more trauma, because the vast majority of our trauma, they are from vehicle collision. So in this case, for example, we have seen that our system is less under stress for the usual situation. Other thing that we can do is just to cancel all the elective procedure, as Vanni was telling before, that they are not urgent or emergent. What you can do is to avoid to do oncologic surgeries that they will go to deteriorate in 1 month. So most probably you need to do those surgeries, and we are doing that actually. How to manage the patient? For sure, if you are aware that the patient is positive or he has a disease, for example, is coming from the ICU, from the COVID area ICU, you should manage the patient, and you need to bring him or her to theater for another surgery. You need absolutely to take all the third level protection for the people involved in that surgery. What to do for patients that they are coming for an emergency situation and they are not symptomatic, or for those elective patients that they have an oncologic problem, and you need to be to operate on them. In that case, according to me and according to what we have done now, we are taking for the anesthetist and the nurse that is helping the anesthetist the third level protection, personal protection level. For the other one, when the patient is ventilated and the other one, they are not in danger and they don't have a risk of contamination, we just take the usual protection that we take usually in any surgery, in any emergency surgery in theater. I don't know if I answer to the question that you did to me. To answer to the 8th question, what what advice I wish you could have given to myself 2 weeks ago to manage emergent non-COVID patient. Actually, according to the first topic, we were not prepared to the mass casualty. This is the problem. So actually, what is my advice is for hospital that they should afford this kind of problem is to really to review the mass casualty protocol. Second one, instead, is how to manage the patient in theater. For sure, even there we don't have a particular protocol for those patients. We need, or those hospitals that they will afford this kind of patient, they should look after to have a protocol in theater maybe one idea can be to have theater only for COVID-19 patient, and other one for suspect or for asymptomatic patient. Thank you very much.
Okay, we have some questions.
Yes, we do. We have quite a few questions coming in. So one question is regarding scheduling and therefore canceling of elective surgeries. Looking back at your experience now, what would that window look like? Would you be looking to cancel elective surgeries several weeks out? Are you looking at several months out? What does that window look like?
Actually, according to what is my experience in this moment, you should consider at least a couple of months before. I mean, we have not canceled the patient. We keep the patient on the list, and we tell them that they should postpone the surgery for at least a couple of months.
All right, the next question. For the elective or urgent procedures you're doing, are you using full PPE given the high rate of community transmissions and the fact that there's aerosolization of the virus during airway management?
Not for all the patients, actually. Only for those patients that they are positive. I tried to tell you what has happened yesterday. We have a patient with a discitis and with an abscess in a psoas, in the right psoas muscle. In a lady that he has developed a sepsis due to this. We have tried to make just a drainage without opening her, and the drainage was not enough. She's still on fever. So yesterday we planned for a surgery. The patient is in hospital still since 15 days ago. Actually, 2 days ago, and she was in a medical department, and 2 days ago they decided that because she has fever to test her. And when we reached theater, the result of the test was still not out. So we decided, because it was not so emergent, the situation, in order to drain the abscess, and she can wait at least a couple of days to wait for the test. Today the test was negative, so most probably we are going to make a procedure tomorrow. I don't know if I answered to your question with this example.
Right. So I think the question that many of us have is that there is a shortage of PPE, and therefore we are wondering if the use of full PPE is always done if you do not know what the status is of the patient.
No, we do. We wear full PPE only for patients that are positive and they are sick for COVID-1. We are just taking the usual protection for theater for all the other patients.
Okay, I'll move on to the next question. Are you continuing with transplant surgeries?
We are not in a transplant hospital, but I know that my colleagues, For example, in Bologna nearby, they do.
What would the panelists advise to approach all elective, urgent, and emergent cases if a patient is in non-tested and even asymptomatic patients? Would you advise us to approach all elective, emergent, and urgent cases in non-tested and even asymptomatic patients as if they were COVID-19 positive? And I will preface this by saying that in the United States, our testing currently is probably not as accessible. We are not able to run as many tests as other countries.
Actually, first of all, regarding testing, being involved in the screening of the patient, in at least 20% of the patient that they have a CT scan positive is test negative. So even doing a diffuse testing for a symptomatic patient, I don't think that there is a rationale to do that. Instead, to decide which patient have to go to theater and which kind of protection you should use, first of all. Second thing is that actually is the question that you are doing now is just the reverse of the question of before. We don't have enough protection for all the patient, for the personnel, for doing all the patient that they are coming to our theater in this moment. So the only thing to reduce the risk is to reduce the number of surgery that we are doing, to take protection for the patient that they are truly and for sure positive, and to do our best for those patients that should have emergent surgery or oncologic urgent surgery, elective surgery.
Thank you. Next question. Are cardiac surgeries being performed? And if so, which types of cardiac surgery?
I don't have data. I don't have data because actually our hospital is not an hospital with that does heart surgery. According to what I know, even for what the other colleague they are telling me, they try to reduce as much as possible the surgery. They do only those surgeries that they are for sure absolutely you should do absolutely, because the patient is not for that surgery. But really, we are not an hospital with a heart surgery available, so I cannot tell you if in which size the cardiac surgery is still done in Italy.
Okay, maybe time for one last question. How have you, if you know, you may not know how this is done, but how have you managed cleaning of the rooms in the ED or the CT scanner or the operating room after a PUI is passed through? And what about unknown asymptomatic patients?
Okay, actually, normally the disease is a droplet and contact. The risk is due to droplet and contact. So the usual cleaning of the theater, normally it should be enough to clean everything on the contact and on the area that they were at least in theater, that most probably they were contaminated. So a deep cleaning of the of the theater should be enough. On the CT scan, actually, I don't know if there is any protocol for taking any particular I mean, if we take any particular precaution in order to clean the CT scan. But I will try to have an idea tomorrow.